Dear senior doctors of the profession, I am a junior doctors network team, medical student network team, postgraduate and undergraduate students and colleagues. A very good evening to all. On behalf of our chairman, directors and the entire Sundaram Alraj Hospital team, we welcome you all for a monthly virtual CPC meeting. We shall now start our virtual CPC meeting with the interesting quiz questions. In this first, we have an interesting ECG of a 55-year-old male who came to the emergency with complaints of chest pain since morning, which got subsided on its own after a few hours. On examination, his BP was 130/70, pulse rate was 84 per minute, saturation was 96% at room air, trop I was 123, and CKMB was 5.3. His ECG is shown here. What are the findings you can see in this ECG? With this, what is the syndrome you can think of? What is the pathophysiology behind the development of this syndrome? What do you think could be the cause of this condition? What are the differential diagnoses of anterior leads T-wave inversion you can think of? And also, what are the differential diagnoses you can think of when you have a biphasic T-wave in the ECG? Next, we had a 5-year-old girl who was brought to the emergency with a history of having swallowed a gold ring while playing. On examination, the child was active and alert. Systemic examinations were normal and X-ray was immediately taken, followed by which, what do you think is the finding in the X-ray? With this finding, how will you proceed? And you can see clearly what has been done and what they have found. What are the complications you can think of because of this procedure or because of having swallowed the ring? Next, we had a 45-year-old male who came to our OPD with sudden onset of pain, redness, and swelling of the right metatarsophalangeal joint of the great toe. On examination, he was conscious oriented. His systemic examinations were normal. His hemoglobin was 14.2, total count was 11,000, and to differential count also 65, neutrophils, blood sugar was 167, urea was normal. His serum uric acid was 8.2, serum ASO and RA factor was negative. The clinical picture of his great toe is shown here. What does this picture show? What's the diagnosis you can think of from this picture? What do you think would be the cause of this condition? What are the different types of this condition you can think of? What is the treatment you will give for this patient? Why certain drugs are contraindicated in this acute attack? And for this acute symptoms, what will be the other differential diagnosis you can think of? Next, we had a 51-year-old male, a chronic alcoholic and smoker, who came with on and off epigastric pain radiating to the back since 2 days and also 4 episodes of vomiting. On examination, his vitals were stable. He was afebrile. Per abdomen, there was tenderness in the epigastric region. With this history, what will be your clinical diagnosis? How will you proceed to evaluate him? So after the routine investigations, an ultrasound was done for the patient. The picture is shown here. What are the findings in his ultrasound? Followed by which a CT was also done since the pain did not subside. The CT picture is also shown here. What do you think could be the CT findings? And with this, what will be your final diagnosis and how will you proceed to manage him? Next, we had a 59-year female who was admitted with complaints of nausea, vomiting, chest burning sensation for past 1 week. She's a known diabetic on irregular treatment. Her vitals were stable. With this history, what will be your clinical diagnosis? How will you proceed to evaluate her? She was subjected to an endoscopy or UGScopy. The pictures are shown here. What are the findings you can see in this picture here? So with this, what will be your final diagnosis and how will you manage this patient? Next, we had a 40-year-old male who presented with exertional breathlessness and palpitation for the past 2 days. On examination, his BP was 130/70, pulse rate was 112 per minute, saturation was 92% at room air. He was conscious, alert, and ECG had been taken for him. The ECG is shown here. What are the findings you can see in this ECG? How will you proceed to evaluate him? If an echo had been done for this patient, what do you think will be the echo finding for this patient? Sorry, we could not put the echo today. The patient was subjected to a CT pulmonary angio. The pictures are shown here. What is the finding in this CT pulmonary angio, which you can see here? With this, what will be your final diagnosis and how will you proceed to manage him? Next, we had a 58-year-old male, a known case of COPD, who came to our emergency room with breathlessness. He was conscious, oriented, restless, and tachypnic. On examination, auscultation, he had bilateral wheeze as well as bilateral basal Krebs was there. Pulse rate was 111 per minute. Saturation was only 76% at room air. BP was 150/90. The routine treatment was started for the patient and an ABG was done for him, and which is shown here. What does this say? What is the diagnosis from the ABG here? What are the other differential diagnoses you can think of for this condition? And with this diagnosis, how will you manage? And how will you manage this case? Next, we had a 52-year-old man admitted with a decompensated liver disease in hepatic encephalopathy, portal hypertension, along with hematemesis. He was stabilized and an EEG, other than the routine investigation, an EEG was also done for the patient. The EEG form picture shown here. What do you think are the findings in this EEG here? How do you interpret it? What are the causes you can think of? What are the other different types of normal EEG waveforms you know of? Next, we had a 67-year-old female who came with complaints of giddiness, loss of vision since 3 days. She's a known case of a diabetic, a hypertensive for last 15 years on regular treatment. On examination, she was responding to oral commands. Bilateral plantar was flexor. Power was normal in all the four limbs. Her visual acuity, hand motion was present, and light perception was there. EOM was full. Bilateral fundus was normal. Pupil reflex was present. With this clinical history, what is your clinical diagnosis? How will you proceed to evaluate her? Immediately a CT was taken for her. The CT picture is shown here, followed by which an MRI was also done. Its pictures are also shown here. What are the findings you can see in both the CT as well as the MRI? How will you differentiate between cortical blindness and other causes of blindness? What is Anton syndrome? And with this, what will be your final diagnosis? Thank you. So, as delegates are thinking over the answers for the quiz questions, we will start our meeting with a prayer as everything starts with the Almighty. Physician's prayer. Dear Lord, thou great physician, I kneel before thee, since every good and perfect gift must come from thee. I pray, give skill to my hand, clear vision to my mind, kindness and sympathy to my heart. Give me singleness of purpose, strength to lift at least a part of the burden of my suffering fellow men, and a true realization of the rare privilege that is mine. Take from my heart all guile and worldliness, that with the simple faith of a child I may rely on thee. SAH prayer. Almighty Lord, source of pink health, we submit our heartfelt gratitude for healing the dreadful and the chronic patients through our hands. Bless our Sundaram Maruraj hospitals with all the doctors and staffs. Let them shine up in their efforts to heal the sick and develop the science of medicine. We thank you, O Lord, for picking us for health services to create the healthy longevity for healthy citizen and healthy, vibrant India. We shall now start our CME. The first session for this evening will be on an interesting case of the misdiagnosis of acute leukemia presented as arthritis, which will be presented by Dr. Manikandan sir, consultant medical oncologist, Tenmani Hospital and Sundaram Raj Hospitals. Over to you, sir.
Good evening, everyone. I'm thankful to the Aarti ma'am for this kind opportunity, and I would also congratulate Arul Raj sir and team for this great effort on continuing medical education. So today I'll be presenting a patient on acute leukemia that is presented as arthritis. So this is a 25-year-old boy. Actually, he's a son of a fisherman. He has presented with a long history of joint pain, swelling, and myalgia for around 9 months. He has consulted multiple doctors in Thuthukudi, and he has received multiple courses of oral steroids, methotrexate, and multiple analgesics. Until on the final day, he was referred to me by Dr. Subramaniam, senior nephrologist from Thothukudi. On examination, his performance status was 3. He was wheelchair bound. He had arthritis of multiple small joints. He had pallor. He had small cervical lymph nodes. There was no hepatosplenomegaly, and his vitals were stable. His investigation showed anemia, hemoglobin of 8.8, white cell of 3,300, platelets were borderline low, 1.44 lakh. And his peripheral smear showed sheets of blast suggestive of acute leukemia. His bone marrow study showed more than 90% lymphocytes, and flow cytometry confirmed it was an ETP type of acute lymphoblastic leukemia. So this was his peripheral smear. You can see multiple lymphoblasts that are slightly larger than the size of the red blood cells. And this is his bone marrow that shows sheets of lymphoblasts studded in the bone marrow. So his immediate treatment was he was started on oral morphine along with IV paracetamol and hydration to prevent tumor lysis syndrome, and he was transfused with Paxils, and he was also given allopurinol to prevent tumor lysis syndrome. So subsequently, I had referred him to government uh, general hospital in Chennai, where he has completed induction 1. So for acute leukemia, ALL, induction comprises of multi chemotherapy drugs that includes steroid backbone, prednisolone, vincristine, daunorubicin, L-asparaginase, intrathecal methotrexate. Subsequently, his bone marrow was in remission. Currently, because this boy doesn't want to go to Chennai, he is receiving induction 2, that is cytosine aragonacide, in Thuthukudi. And he has also been planned for haploidentical stem cell transplantation, which is with his sibling in few months now. So a brief uh, idea about acute leukemias. In general, acute leukemias comprise of either acute lymphoblastic leukemia or acute myeloid leukemia. Acute lymphoblastic leukemia, usually it is a younger age, and all leukemias, acute leukemias have a very short history, either fever or bleeding. And in general, ALL presents with lymphadenopathy, hepatosplenomegaly. Also, patients can present with large mediastinal mass, pleural effusion. Also, acute lymphoblastic leukemias can present with testicular involvement. Presentation as an arthritis is very uncommon and has been documented in less than 5% of presentations of acute lymphoblastic leukemia. So investigations, we have to remember any patient, sick patient who presents with fever and bleeding, immediately we have to do a complete blood count along with peripheral smear. So usually acute leukemias have anemia. Predominantly they can have leukocytosis. Also a small component less than 10% can have leukopenia. And mostly acute leukemias present with thrombocytopenia. This patient who had presented did not have a presentation of thrombocytopenia. Platelets were normal for majority of the time. This is very uncommonly reported in less than 5% of presentations of acute leukemia. In general, the bone marrow, the peripheral smear has sheets of blasts, and also we do bone marrow to confirm the diagnosis of acute leukemia. Usually, acute lymphoblastic leukemia have lymphoblasts of more than 20%. And currently, flow cytometry has to be done because all sometimes aberrant expression of acute lymphoblastic leukemia could present like AML, and it is mandatory to do flow cytometry to differentiate ALL and AML. And also in the current era where all the treatments, especially the high-dose chemotherapy stem cell transplant, is based on the molecular risk profile. So earlier we thought acute leukemia was one disease. Subsequently, we found acute leukemias is two types, ALL, AML. Now we know ALL is hundreds of different types of leukemia, and each molecular subtype has a separate treatment category. Some of it has targeted therapies, oral therapies, and some of the acute leukemias we have to consolidate with high-dose chemotherapy. And in general, if you compare ALL and AML, ALL has a good prognosis. Pediatric acute lymphoblastic leukemias have a survival of more than 90%, 5 years. So in general, the treatment for all acute lymphoblastic leukemias consists of combination chemotherapy with steroid as the backbone, vincristine, daunorubicin, L-asparaginase. And we also know that most of the leukemias, if they are not treated adequately, eventually they will have a CNS or a testicular relapse. To prevent this, all these acute lymphoblastic leukemias, CNS prophylaxis in the form of intrathecal methotrexate and also high-dose methotrexate that crosses the blood-brain barrier is mandated. And also for T-cell ALL and other high-risk ALL, prophylactic cranial irradiation is needed to prevent a cranial relapse. Also, we know that there are certain groups of high-risk ALL. So this patient had a high-risk ALL, that is ETP ALL, and his age was more than 9 years. Consolidation high-dose chemotherapy followed by allogenic stem cell transplantation is needed to prevent an imminent relapse. And also the other pointers of high-dose chemotherapy is somebody who is not in morphological remission. that is blasts not less than 5% after induction. Also, MRD, molecular residual disease, positive after induction. And there are certain types called as pH positive ALL. The BCR-ABL gene is mutated just like in CML. These patients have a high risk of relapse, and these patients need consolidation, high-dose chemotherapy. And all leukemias that have relapsed has to be consolidated with bone marrow transplant for a long-term cure. So moving on to the other type, acute myeloid leukemias. In general, the presentation is of older age. And again, all acute leukemias present with fever and bleeding. It is very important for us to diagnose very early because we may lose these patients either due to fever related to infection and sepsis or bleeding, that is intracranial bleeding. Most of the registries do not capture the exact number of acute leukemias because not majority, quite a lot of patients are actually dead by the time they report to hospital. AML generally doesn't present with lymphadenopathy or hepatosplenomegaly. Also, older age patients presenting with pancytopenia keep at the back of the mind either acute myeloid leukemia or myelodysplastic syndrome. And the investigations pattern is similar to ALL, that is a CBC, wherein you can detect anemia, either leukocytosis or leukopenia, and thrombocytopenia. And kindly do not forget a peripheral smear in any sick patient who presents with high fever or bleeding manifestations. Again, the bone marrow study reveals a myeloblast more than 20%. Flow cytometry is mandatory to differentiate AML and ALL. And again, we need molecular studies to categorize which patients would need targeted therapy or which patients we need to consolidate it with bone marrow transplantation. So this is a peripheral smear wherein you can see the myeloblasts, which are actually large and have lesser chromatin as compared to the ALL. In general, all AMLs have a poor prognosis. The only exception is acute promyelocytic leukemia. The treatment for all AML is very, very intense, wherein there is something called induction 3+7 regimen, wherein 3 days of daunorubicin and 7 days of cytosine arabinocyte chemotherapy is given. The patient becomes very neutropenic for the next 2 weeks, wherein the patient can have bleeding, for which we need to supplement with Paxils and platelet support and FFPs. If any fever, we need to escalate to the highest antibiotics. And once induction is over, they need to be consolidated with high-dose cytosine arabinocyte. And also based on the molecular risk profile, if their molecular risk profile is high, we need to consolidate with high-dose chemotherapy and allogenic stem cell transplantation. Just a word of AML. There is one subtype of AML that has got a very, very good prognosis provided these patients are diagnosed early and treated early. And these patients could be younger predominantly. Some of them can be older patients. They present with gum hypertrophy and they present with massive bleeding diathesis. Like if it is a woman, they can have bleeding gums, they can have melena, they can have bleeding PV, they can have multiple subcutaneous ecchymosis at injection sites, and also they have coagulopathy. And these patients, we need not treat them with chemotherapy. We need to treat them with differentiating agents. One among them is arsenic trioxide. So arsenic trioxide, I would like to mention that CMC Vellore was the first center to actually incorporate arsenic trioxide in the treatment of AML, and this arsenic trioxide has been world over followed by multiple institutes. Before arsenic trioxide, we also had ATRA, all-trans retinoic acid. This is a differentiating agent, and there is no chemotherapy that is needed in acute promyelocytic leukemia, excepting in those patients who present with the high white cells, wherein we need to do a cytoreduction with a low dose of chemotherapy. So if there are any residents, this is one slide, take-home slide you have to remember. If a peripheral smear or bone marrow shows these extensive granules and there are something called OR rods, if they are seen, this is a pathognomonic diagnosis of acute promyelocytic leukemia. And these patients you might lose the patients within few hours. So at the earliest, you have to start them with hydration and start them in arsenic trioxide or all-trans retinoic acid. So just about bone marrow transplantation, this is actually totally different as compared to any organ transplantation. And this is totally a medical procedure wherein the first patient is the donor, wherein the blood is collected by the apheresis machine. And from the blood, stem cells that are CD34 positive cells are collected and stored in the refrigerator. And the second slide is the patient where instead of the regular chemotherapy, high dose chemotherapy, that is 5 to 10 times higher the dose of chemotherapy is delivered, and the bone marrow of the patient is completely depleted. His white cells will be zero, platelets will be 10,000, 20,000. He will have severe anemia. At that time, the stem cells that had been collected from the donor is infused, and there is a process called homing. Very, very interesting. The stem cells that you give in the peripheral vein of the patient actually goes, and it actually goes to the bone marrow, sticks to that bone marrow of the patient, and it starts developing the cells. So the second week after the bone marrow transplantation, gradually the patient's neutrophil from 0, it improves to 100, 200, and it goes beyond 1000. And early after the neutrophil recovery, that is neutrophil engraftment, we have something called platelet engraftment. Gradually, the platelets of the patient would improve. So from this patient, maybe this is for the residents, if there are any residents, what is medical reconciliation? If anybody can tell that. So this patient had actually a basket full of medicines. So 8 months, he has consulted more than 15 doctors. He has taken all the possible drugs, paracetamol, aceclofenac, ketorolac, diclofenac, and all groups of oral steroids, prednisolone, dexamethasone, methylprednisolone, deflazacort, and also he has received methotrexate, considering a diagnosis of rheumatoid arthritis. So as clinicians, especially if it is a long history, multiple doctor consults, it is very important for us to go through a very detailed history to identify all the drugs that the patient has received, so that we would not repeat certain group of drugs that has been given. Especially this is very important on inpatients, especially during transfer from ICU to the ward. Also, all the nursing team, especially for inpatients, need to know what is medical reconciliation, because you may never know, the patients might be on alternative medicines, traditional medicines. So it's very important for us to identify what drugs the patient currently is taking and to give a revised prescription. And some of the questions to the residents: should we give pre-medications before blood transfusion? So traditionally, we give either Avil and steroids for pre-medication. So current recommendation, there is no pre-medication needed, especially when you give a packed cells for a patient for whom we do not know the cause of anemia. The primary reason is a single dose of a steroid, that is hydrocortisone 100 mg, can put a patient with acute lymphoblastic leukemia on remission. Acute ALL is very, very sensitive to drugs, especially steroids. That's why they have a very good prognosis. In Cancer Institute, we have seen many patients, especially who has received pack cells multiple times outside. They will have a clear history and earlier investigation suggest of acute leukemia. But when we do the bone marrow will show a lot of treatment-related changes, and the pathologist would not be able to comment that the patient has acute leukemia. So these patients are subjected to multiple bone marrows every visit, and bone marrow is one of the cruelest procedure that a patient can ever receive. So who should perform a bone marrow study? So it's preferable a hematologist or a medical oncologist or a physician with an experience in doing a bone marrow study. It is always preferable, and preferable not to be done by a pathologist or an orthopedic surgeon. I will tell you the reason why. So this is the bone marrow aspiration needle. This is the Illinois bone marrow aspiration needle. This is the preferred needle for bone marrow aspiration needle. And this is the Jamshidi bone marrow biopsy needle. This is the preferred needle for doing a biopsy. So earlier we were using the stainless steel needles. Currently this is not anymore in use. I will tell you the reasons why. So if there are any residents, can you comment what is this X-ray showing? So this X-ray is actually showing, if you look at the arrow, that is a small needle. It's a broken needle in the posterior superior iliac crest. So especially some of these stainless steel needles, earlier we were autoclaving and using these needles. Some of them are very thin, and especially if it is a very obese patient or pre-treated patient, sometimes some of these bone marrow needles can break in. So this could be a very serious problem wherein you have to immediately incorporate an orthopedic surgeon with under general anesthesia. Somebody who's acute leukemia, you may not be able to do it. So I'd actually encountered this during one of our residents had done bone marrow needle during my training days in Cancer Institute. So can anybody here, if any residents can tell what what is this CT scan showing? So this is actually CT scan of a patient with a large retroperitoneal hematoma. So you have to be very, very careful, especially if it is a myeloma or somebody with bone mets. So sometimes bone marrow, you might be giving all the pressure to get the bone marrow biopsy. Sometimes you might have a lytic lesion, bone marrow lesion, especially in myeloma or bone mets. So suddenly it can give way. So if the patient has coagulopathy or low platelets, you might end up in having a large retroperitoneal hematoma. One of my juniors actually in Coimbatore had actually encountered this. So, and also if it is an obese patient, it is very difficult. Even for a trained person to do a bone marrow, it's very, very difficult. And also never ever do a bone marrow biopsy on a sternum needle. So one of the surgeons in Thuthukudi actually had done bone marrow biopsy on the sternum. So sternum is a very, very thin bone, especially in patients with myeloma and or bone mets, they can have lytic lesions and easily it can give way. And there is actually a guard, the latest, Illinois, uh, the Illinois bone marrow needle actually a sternal guard. So only for with using a sternal guard, you have to do a sternal bone marrow aspirate. So how much sample? So it's very important for the treating team to take a decision on bone marrow sample. The primary reasons are, yes, sir.
Your I mean, extensive talk is very good, but time you have limit crossed. Other person is waiting.
Yes,
Kindly,
in 2
kindly.
minutes, yes, sir. Last few slides. So how much sample? So it's actually, you have to do unstained slides, 4 slides, EDTA 2 ml, heparent 2 ml, and bone marrow biopsy 2 ml bit. So where to sample? It's preferable to send to qualified labs like Ampath, Agilus Diagnostics, or Anderson. So some of the challenges in Thuthukudi currently, we are unable to treat. Primarily, we need a HEPA filtered induction room and bone marrow components separated for the single donor platelets, and we also need irradiate blood components. And the latest, this is the last slide for today, that is the CAR T cell therapy. That is the latest for all acute, especially refractory leukemias. It has shown a promising cure. Unfortunately, it's very expensive. The take-home message for all residents is if you have a sick patient with fever or bleeding, never forget a CBC and also a peripheral smear that could save lives. Again, thank you, ma'am. Thank you, Arulraj sir, for the kind opportunity.
Thank you, sir, for your extensive talk, excellent case presentation. As of now, we don't have much questions in the chat box. Can we take it over to the next speaker, sir? If there are any questions. So since there are no more questions, we shall now move on to the second session, which will be an interesting case, vignettes in diarrhea, which will be presented by Dr. Sai Raman, Assistant Professor of Gastroenterology, Thuthukudi Medical College. Over to you, Dr. Sai.
Good evening, one and all.
Good evening. Yeah.
Thank Arulraj sir and Aarti madam for this opportunity. Here I'm going to present interesting case vignettes on diarrhea.
Sairam sir, you're not audible. Yeah.
Madam, am I audible now?
Yes, sir, you're audible, but it's a little soft. Yeah.
So diarrhea is altered stool frequency and consistency. The volume of diarrhea being more than 200 ml or the weight being more than 200 grams. For Indian population who take a high fiber rate, it is almost 300 to 400 grams. So first thing as a physician or a general practitioner, what we should do is we should look onto the stool for examination. For example, you can have the first slide of a patient presenting with the diarrhea and dyselectrolytemia. The gross examination finding is rice water diarrhea, which is pathognomonic of cholera. And one more thing we should look into the examination in any chronic diarrhea will be fat globules. When fat globules are present, they diagnose pancreatic maldigestion and malabsorption. And paradoxically, when we look into the stools of patients with chronic diarrhea, there may be pelletized stools, which is they have chronic constipation with impaction of stool, which causes overflow diarrhea. So that may also be the reason. So this is very important why we have to examine the stool. And one more thing, this I had a pediatric age child presented with recurrent bloody stools. So on gross examination, this is a recurrent jelly stool of intussusception. And the word diarrhea literally means a flow through. And here I have one pediatric age group patient presenting with chronic diarrhea. On macroscopic examination of stool, there are multiple bubbles. So which which is pathognomonic of carbohydrate malabsorption. So where you have multiple bubbles with liquid stools. And the chest X-ray which was shown here, the problem is the one thing that was grossly missed was absence of thymus shadow here. So when this patient was extensively evaluated, even with genetic sequencing, we could find out immunodeficiency syndrome, and unfortunately we could not save this child. And here this male presents with chronic diarrhea, dementia, and dermatitis. This is a classical spotter of Castle's necklace, which is a pathognomonic of pellagra, which is niacin deficiency. And in all diarrhea patients, look onto the perianal region for skin excoriation, especially in pediatric age group. This is a classic acrodermatitis enteropathica, diagnostic of zinc deficiency in chronic diarrhea. So now we will move on to the clinical cases. The first case, he's a middle-aged male with 1 week abdomen pain, loose stools, and the CT abdomen. He had a pancreatic malignancy with liver and gastric infiltration and advanced malignancy. So we took for colonoscopy. Colonoscopy showed multiple erosive lesions, which is classically described as tomato splash appearance. And once we took a biopsy, we could make out owl's eye inclusion, which is characteristic of CMV colitis. So any immunocompromised patient presenting with acute onset diarrhea and abdomen pain, think of viral as well as opportunistic infection as the cause. This is the take home from this case. And second case, here this patient has been treated as irritable bowel syndrome, diarrhea type for 2 decades. In a local hospital, he presented to us with diarrhea. On stool microscopy examination, we could make out giardias. This is fallen leaf motility of giardia. So when I extensively evaluated, he had a pulmonary involvement as well as involvement of duodenum as well as large bowel. Biopsy showed giardia lambia in the lumen of D2 as well as lymphocytic gastritis. So he was evaluated. He had a low IG serology, IgA, IgM as well as IgG. So he went on into CVID, chronic variable immunodeficiency. And further, we investigated him with IHC and we could make a diagnosis of chronic variable immunodeficiency, which has transformed into a malignant variant. That is immunoproliferative small intestinal disorder. And third case, presented with chronic diarrhea and grossly normal colon with just a patchy erosion in ascending colon. So when we took a biopsy, it came as collagenous colitis. So collagenous colitis and microscopic colitis are variants of third variant of inflammatory bowel disease, which one should keep in mind when the diarrhea is not settling, because when chronic diarrhea is there with a normal colonoscopy and with all medications given, we will be tempted to make a diagnosis of IBS. So meticulous colonoscopy and biopsy at times will prove the etiology. This is a thick collagenous band. This is the etiology for diarrhea. Simply giving steroids or treating the underlying condition will emphasize or will stop the diarrhea. And this is 34-year-old male. He again presented with chronic diarrhea with nocturnal episodes. Again, when someone has diarrhea with nocturnal episodes, again, it is one of the warning signs. He was treated as IBSD initially, and then he became diabetic and he was thought as metformin related. So colon was normal grossly, and there was no worm infestation and no constitutional symptoms, but he had hypothyroidism. Since he had more than once his organ stem involvement, I took a biopsy from the colon and it came as lymphocytic colitis. So we started him as steroids with mesalamine and his symptoms totally waned off. So take home message is, whenever someone has hypothyroidism with chronic diarrhea, with even a normal colonoscopy, he warrants a luminal biopsy, mucosal biopsy. And here is one patient who has been presenting with gastric outlet obstruction as well as ileitis. She was treated elsewhere as tuberculosis, but the classical presentation is she had episcleritis, which is a nodular type, and on luminal examination there was ulceration. This is the upper GI lumen showing florid ulceration with gastric outlet obstruction. So we just started her on azathioprine as well as mesalamine and IV steroids. So she symptomatically improved and she's on follow-up. She's on 3rd month follow-up now. And her main presentation with gastric outlet obstruction with diarrhea. And here this is an interesting patient of inflammatory bowel disease who was treated with multiple antibiotics, who developed again diarrhea with fever. So now when we did a colonoscopy, we could find out white patches in colon, and on biopsy, it was suggestive of pseudomembranous colitis. So this is classical volcanic sign in histopathology, which will be multiple exudates of neutrophilic exudates will be seen, and grossly they will be resembling membrane. So again, one more thing is, even though patients are IBD, whenever they are presenting with diarrhea in each episode, take the history properly and then look into a luminal examination that will be yielding. So this is the colonoscopy of an inflammatory bowel disease patient showing multiple pseudopolyp as well as ulcerated lesions. So again, you can see stools coming in. So the dictum is, whenever someone is having acute ulcerative colitis, never prepare them bowel preparation before colonoscopy. So that is one more take home message here. And this is one more interesting case which was presenting as chronic diarrhea. When I did a superficial upper GI endoscopy, it was normal. So there is one upgrade in upper GI endoscopy called narrowband imaging technology. So with which, when I picked up, so you can make out an ulcerated lesion here, which was missed in gross eye. So you can see this narrowband in white light imaging, it was missed. In narrowband imaging, we could pick it up, and a targeted biopsy was done. Targeted biopsy showed ASCA positive. She had granulomatous duodenitis, and when evaluated further, her IgG ASCA was positive and TB workup was negative. So this is a case of granulomatous duodenitis. Crohn's presenting as granulomatous duodenitis, and this is a chronic 64-year-old male presenting with chronic diarrhea and pedal edema. And this is the upper GI endoscopy. In upper GI endoscopy, the classical spotter was cerebriform pattern of folds. So which was a spotter, and endoscopic diagnosis of Menetrius disease was made out. So targeted biopsy was done, and again CT showed a thickening of gastric rugae, and there is hypoalbuminemia. The RUT for H. pylori was negative, and biopsy showed a characteristic feature consistent with Menetrius disease. And this patient presented with bloody diarrhea. She's a known case of CA cervix. So again, when a patient with malignancy comes, you have to be assessing the lumen carefully. So this is an colonoscopic view showing multiple telangiectatic vessels, classically described as spider-leg appearance. So this is characteristic of radiation-induced proctocolitis. It can present even a decade later. And any patient presenting with chronic diarrhea with intractable hypokalemia, first thing should be ruled out as cholera, and second thing will be villus adenoma. So this is a characteristic tubulovillus adenoma of the rectosigmoid, and this is the biopsy finding confirming it. So again, the dyskalemic diarrhea, always think of growths. And this is the one interesting patient, a pediatric patient. She presented with diarrhea and pruritus. So she had a triangular facies as spotter, and she has a rickets-like deformity, and she had a persistent skin changes also, both in the external surface. So, and this is a posterior embryotoxin, which is classical. And so we proceeded with skin biopsy. Skin biopsy was consistent with the xanthomas, and proceeded with liver biopsy. Liver biopsy, we could make out absence of bile ductules. So this is classical of Alagili syndrome. So we went on with the genetic sequencing. Genetic sequencing proved out to be JAG1 mutation positivity, and immunohistochemistry CK7 was absent. So this patient had absence of bile, which is required for digestion of both nutrients as well as absorption of vitamin A, D, E, and K, fat soluble vitamins. So this is a mal absorptive diarrhea. So this patient presented with anemia with diarrhea. So classical koilonychia, and there is classical scalloping of D2. So, and there was an post-cricoid web on endoscopy. So which we took a biopsy from the scalloping lesion. It was suggestive of celiac disease. The classical villus pattern is absent. So again, on just stopping the gluten diets such as wheat, oat, barley, and rye, this patient's diarrhea improved. And the last one will be young male presented with diarrhea and chylous ascites and chylous effusion everywhere. So since the effusion was chylous, so he was on treated with ATT 2 or 3 times. So the problem is he was not assessed with the luminal endoscopy, and he had this gross finding of neurofibroma. So we carefully examined him. So he had hypogammaglobulinemia, lymphopenia in CBC, as well as lymphocytosis in ascitic fluid. ADA was positive because ADA is synthesized only from lymphocyte. So it can be positive in all disorders where there is lymphocytosis. So we went and looked on for OGD scopy. Scopy showed multiple white patchy lesions in small intestine. When biopsy was taken, it was diagnosed as lymphangiectasia. So on reviewing the article, it is closely associated with neurofibromatosis, and the diagnosis of primary intestinal lymphangiectasia was made. And for his treatment is only low fat diet. So again, one more important thing in the arena of evaluation of diarrhea will be exome sequencing. So which we do in our government Thuthukudi Medical College, where you have this tyrosine kinase receptor mutation in one of our patients, which was done. He was treated as a refractory Crohn's, treated with TYK2 receptor mutation, and he was not responding. So ultimately, we found out that he had a mutation in that receptor for the drug, and also coincidentally an immunosuppressed state overlaying also. So again, in any chronic diarrhea patient, looking on to the stool examination, luminal examination with colonoscopy, and the last resort one should keep in a patient who is refractory to treatment will be genetic sequencing. Thank you.
Thank you very much, Dr. Sairam, for the very interesting cases you have shown us today and various points we need to think when we see a diarrhea patient in our day-to-day practice also. The topic is open for discussion. Delegates, you can unmute yourself and ask if you have any queries. Or you can even post it in the chat box, which they'll be able to take over. As of now, we don't have much questions. So we'll wait. We'll go on to the next agenda. If there are no more questions, we shall now move on to the last session for today, for which we request our chairman, sir, to give his concluding remarks about both the lectures and also to discuss the answers for the clinical album. Over to you, sir.
I must thank both the youngsters who have extensively covered the topics. Highly academic, more than a super specialist presentation. That is why probably people don't have any questions, because first it needs full understanding. Regarding these leukemias, always a clinician should keep in mind leukemia, in which situation. Whenever there is a fever not getting controlled, whenever there is hepatosplenomegaly or a node, whenever there is anemia, whenever there is a skin purpura or bleeding tendency, keep this in mind. Simple CBC will tell you, maybe a leukopenia or leukocytosis. But we need to do a peripheral smear. That itself will give you the clue, and a bone marrow is always final. We should really thank Dr. Manikandan, and after confirming it, you can always transfer to Manikandan. Secondly, diarrhea. You may all think it's a very common problem. Every day we treat with multiples of antibiotics and probiotics, and then, loperat, this and that, whatever it is. That is not the way. When a diarrhea is recurring, always you should think there is something else there. And you should see that a colonoscopy has to be performed, and performed by a gastroenterologist. It gives you the diagnosis. Diarrhea goes beyond infected diarrheas also. That Sairam has done well. I am sure people have been much educated. Now over to the clinical album here. The first one is a very interesting one. 55-year-old man had a chest pain, suggestive of a myocardial infarction. Had markers and enzymes elevated. See the ECG in the anterior lead, there is a T wave inversion, which is not a classical coronary T wave. It is a biphasic T wave. There is a T wave biphasic, upper and lower. This is classical of a transient anterior descending artery plaque or a blocking. There is an occlusion. Either this has been relieved by lysis or by a clot which has gone out. Always you must see that and do an echo. There will be almost an abnormality. Ideally proceed towards an angiogram and try to see what it is. This case had an anterior, left anterior descending artery proximal lesion, very tough lesion, and immediately a stenting has been done. The message here is a biphasic T wave, never ignore. It can be Valence syndrome. Immediately the patient has to be sent for an angiography. Second one is interesting. Many times we have put in there. I am trying to put it to make our participants understand that a foreign body in a GI tract is very common, especially children. Even yesterday, a child swallowed a small battery. Coins we have seen many times. This is a gold ring. See, earlier we have to, so I mean, if it is soft, not a problem, we can always wait for 3-4 days, gives laxative, see the stools and try to get it. Now that is not the way. We do an interventional endoscopy. Today it is an era of intervention. Any branch, either gastroenterology, neurology, cardiology, nephrology, era of intervention. Therefore, we need to do that. Thanks to Ram Subramanian who does this job, I mean, adequately. This is a arthritis. A 45-year-old man comes with an arthritis in the proximal metatarsophalangeal joint. Metatarsals here, phalangeal here. Here there is a pain and there is a restriction, small swelling. This is a classical. If you see that, you can always make a diagnosis of a gout. This is the swelling is a tophi. You see that well in the X-ray. It's a due to hyperuricemia. In acute phase, you can always withhold your for the drug for hyperuricemia. You can always keep it in reserve, and you will have to go immediately with anti-inflammatory drugs. I for the one use a mefenamic acid. After that, you just continue the drugs for the hyperuricemia also. That is a message here. It's a very classical case. And then, alcoholic abdominal pain. Classically, if you see the pain from the epigastrium, it is penetrating into the back. That always think that it is pancreatitis, unless proved otherwise. Simple pain and then regurgitation, this and that may be due to gastric. But there is an epigastric pain which is going into the back, penetrating into the back. Always consider clinically a pancreatitis and treat it accordingly. Immediately do an MLA, do an ultrasound, it is fine. And usually a CT scan of the abdomen is a gold standard. Can tell you whether head is affected, neck is affected, body is affected, tail is affected, how is the pancreatic duct, is there any gallstone? Commonest cause is a gallstone. All these things can be well made out when you do a CT. Therefore, CT is a gold standard in pancreatitis. This you can very easily, if the moment you put in a scope, you can say there are a lot of white patches here. That shows moniliasis. Moniliasis in the esophagus always means a lack of immunity. This chap is a chronic diabetic, uncontrolled diabetics always, favor or encourage, a fungal growth in the esophagus. In the other parts also, it can come even in the colon. Therefore, good control of diabetes is needed along with intravenous. We don't go for oral, antifungal. Intravenous, fungus always gives it. And the most important thing, not clearing the, monilias which can be cleared. The immune deficiency, you should correct it. Sometimes may need even, blood or fresh frozen plasma. It's a very interesting thing when there is somebody comes with the breathlessness. Breathlessness in the world has two causes. One is cardiac, another is respiratory. Cardiac always it is due to a left heart failure. There are, basal rals. And respiratory usually acute exacerbation of COPD, and this is usually having a wrong. By that we try to differentiate pulmonary second source. But there is another important cause is coming up, which clinicians by the bedside must remember: pulmonary thromboembolism. From the legs or from the pelvic vein after surgery or after lying down in bed, thrombus starts and it migrates into the heart and affects the pulmonary circulation and causes an acute chest pain. And clinically, when you have rule out cardiac and respiratory, you must think about it. The clue will be from the ECG. Here, S3, Q3, S1, Q3, T3 is always typical. Even if it is coronary artery disease, try to rule out a pulmonary thromboembolism. Do an echo for this fellow, you will have a dilatation of the right atrium and ventricle, and sometimes you may be able to visualize a thrombus in the main pulmonary artery. But and a peripheral venous Doppler will tell you whether there is a thrombus or not. Sometimes the pistol, could have been shot, and the gun, a shot may be empty. But a pulmonary thromboembolism, you should always do a CT pulmonary angiography, which is a non-invasive investigation. You can very well make out the presence or absence of thrombus, what is the extent of it, what is the seriousness. Here there is an extensive thrombus here, and which has been confirmed. And now you can do a thrombolysis. either intravenous or intrapulmonary also, put in a catheter and do that, and try to evacuate the thrombus also. But usually with the heparin, it goes on well, and long-term oral anticoagulants, rivaroxaban, something has to be done. If there is there are recurrent thrombi coming up, an inferior valve, inferior vena cava, you'll have to put in a filter, because from the leg, it comes to the IVC. From there only it goes to the right atrium and then right ventricle. You can block it at the just below the renal veins, and inferior vena cava filter can be done. Now the importance is in a chest pain or breathlessness. Always keep in your mind pulmonary thromboembolism can be diagnosed and managed. Here a patient with the chronic COPD has come out with the wheezing, and the ABG shows a respiratory acidosis, and CO2 is also very high. And this is very classical for an acute exacerbation of COPD. You can give a steroids, you can give a bronchodilators, antibiotics, everything, but a ventilatory support is needed. Non-invasive ventilation, something like a BiPAP, is very, 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 very useful. And patients, this ABG reverses, and then you put him on regular antibiotics and bronchodilator. This is a chronic liver disease fellow who has got a hepatic encephalopathy. But still, the postgraduate raised a doubt, could it be a CNS lesion inside? You take a EEG first, shows the classical delta waves. Triphasic, 1, 2, 3, this is mostly positive. It is very classical. The other waves are alpha, beta, theta. But this, delta wave always speaks in favor of a hepatic encephalopathy. Once you manage the encephalopathy, this comes back. Right. This is an old lady who is with us with all medical complications: diabetes, hypertension, obesity, hypothyroidism, dyslipidemia, everything. The only problem is she says, I have some difficulty in my vision. She doesn't say that she is blind, some difficulty in my vision. When you check her eye, the people, everything is fine. But only thing is acuity is not there. And is able to, recognize hand movements and light perception is there, but not able to read. And fundus are normal. In this condition, you must think that it could be a cortical. A blindness could be due to a peripheral in the eye or central in the cortex. This condition, it is not peripheral, it is central. And this central always is due to some infarction, do a CT or MRI. Angiography, you are able to make out a posterior circulation stroke, huge infarct is there. This is CT, this is MRI. And this takes time to improve. This patient has a central blindness. Central blind, that is what is called as our Antan syndrome. And with anticoagulants and long-term antiplatelets, these eyesight slowly recovers. I think we have cleared today's clinical album. We should thank all our colleagues who have participated, and young faculties who have shown us a lot of science today. And we'll meet next one. Thank you. Thank you all very much. Good night.
Thank you, sir, for your valuable clinical discussions. We also thank all our delegates. Once again, and let us all meet again next month with another few more interesting clinical discussions. Till then, stay safe and healthy. Good night to one and all.